All right. So we're going to talk about COVID-19, novel coronavirus, SARS-CoV-2, all the same stuff. Does there anybody know what the differences in these are?
COVID is the disease that
Exactly.
causes.
Good job. COVID is a disease that the coronavirus causes, and it's also called SARS-2 because we had SARS-1, and that's the severe version where people get really sick and they have a sudden acute respiratory distress. So our biggest things for us here as EMS, number one is going to be communication. And hopefully we get good communication from dispatch with everything they know, but obviously sometimes they get faulty information and they don't get the whole story because the people don't give it to them. How many times has that happened? And so we have to, but we want to make sure that once we get it, that we communicate properly down the line. So at times you get busy and it's, if you get on the scene and you're taking care of somebody who you're having to intubate and they're sick, it's very easy to focus just on taking care of that patient. If you arrive at the hospital and you go, oh no, we forgot to call, you're probably going to sit there with that patient for quite a while before they take them in because they have all kinds of things they're going to have to do to get ready for that patient. And so they need to know as soon as you know that this is a high-risk patient for coronavirus, COVID, however you want to term it, they need to know right away. The same way that you would a trauma activation in a lot of ways. Because that's going to change how they respond, who they have there. They have to get all their equipment on the same way that you guys do. So that's kind of the biggest thing is communication. There's a lot of flyers going out and different things posted, and people should know that they're supposed to call first. But there are going to be people who are waiting at home who have this virus, and those people are going to sometimes be later getting sick. How long does it take before somebody starts to show symptoms in general until on average they ended up in the hospital?
8 days.
8 days. So 8 days is on average. So those first few days may be pretty mild, and so a lot of times these people will be at home. We'll be calling them from the clinic and things like that, but they'll be being monitored at home. They don't necessarily have pulse oximeters. They don't necessarily know when they're getting bad. They just know when they feel bad. And so they may be calling the ambulance saying, I can't breathe. And it can be, because they cruise along pretty good, but then when they go south very fast is the problem. And so that's kind of the whole problem with this. So, we may get calls on these folks and they may say this is a person of interest. There's a lot of different terms that they'll use, but we need to know so we can notify everybody else. The symptoms of it, okay? I've been dealing with this a lot, talking to different folks. Obviously, we all have, and there are a significant number of people who have positive tests who have no symptoms, who have been tested. There are healthcare workers that we're not really testing those folks, but in some places they are, and so you can have no symptoms and be shed virus. So that's a big thing, so some people have no symptoms. I know we were trying to go to Grand Cayman in June, which probably is now not going to happen. Their first patient that closed their whole hospital was a cruise ship patient who had had a heart attack before all the cruise ships were positive, and this patient was in their ICU after getting treated for his heart attack, starts to have a cough and a fever, and the whole hospital's contaminated because he's had it probably for several days before he had symptoms. So that's one of the big things. Fever, cough, shortness of breath, and achiness are kind of the big four. Those are the things that we tend to see. You guys have probably heard some of the other things. What else have you heard? None? Okay, what else? Anybody else? There's some other weird ones. Headache.
Diarrhea in China.
So in China they had about, depending on what you look at, like 3 to 9%, depending on the study, that initially presented with diarrhea and had no other symptoms, and those people actually did very poorly. So, how do you handle that? How many people do we see with diarrhea? So these are less likely symptoms. I mean, if you look at fever, it's like 80-some%. Cough, it's like 70-some%. So those are really high rates, and so loss of sense of smell and taste, and those can be silent carriers sometimes. Sometimes people who develop symptoms later. Conjunctivitis. I mean, any viral symptoms that you think of, people can get. So you have to watch that. Acute respiratory distress syndrome. Those people go from being fine to their lungs filling up with water, and they are sick in a hurry. And so that's kind of the process that happens with SARS. I mean, when we call it that. So we have to watch for those things. And so time from onset of having virus in your body to when you are actually sick. What's the average on that, do you think? So people are shedding virus before they get sick. So if you get sick today, how many days have you already been shedding virus on average? 3 to 4 days you've already been shedding virus. So you've already been kicking it out of your body for a little while. So that's why it spreads so easily too. How long does it last? I mean, obviously you can see there, if you cough on that table, how long is it going to be on that surface, alive and kicking, ready to infect somebody?
3 to 4 days.
3 to 4 days, 3 days. How about in the air? So if I cough in here, how long is it going to be in the air?
3 minutes.
3 hours. 3 is the right number. So up to 3 hours. So it's droplet spread. Okay, so people will say it's airborne, and that's true and false. Technically, we think about airborne infections as being like TB, tuberculosis, which hangs in the air for a long time because the bacteria actually is able to hang in the air by itself and stay alive. Versus this is only going to stay alive in those droplets, and it's in the air, and droplets have weight, so gravity affects them and that brings them down. So over time, it's going to settle. But if somebody goes through the lobby of the hospital and they think they've had it, they have a recirculation system that recirculates that air every 2 hours, so they got to close things down for 2 hours. If I had a patient who had to go to x-ray the other day who was on precautions, he didn't end up having it, but he needed a chest x-ray for his pneumonia. It's closed down for 2 hours afterwards. So they have a fumigator system, but it's only for small areas like in the ER room, and you can't do like a whole big area. So you have to, those are things we think about. And we'll talk about that a little more as far as how we handle our ambulances afterwards. So timing, obviously up to 2 weeks before people will start, if I have it and you're around me and I cough in your face, it may be 2 days, it may be 2 weeks before you show symptoms. And that makes it kind of hard. That's why we have this 14-day quarantine on people who have been exposed, because we don't know during that time. Like we said, asymptomatic. Why is this such a big deal? Why is it spreading so fast, going everywhere, nailing everybody? So our bodies have never seen it. We have no antibodies.
It's our smallpox.
It's our smallpox when smallpox first came to this country. Yeah, I mean, it's something we've never seen before. It's an animal virus. Went from bats to some other little critter, they think, and then to people. And I forget what that thing is. What's that?
Pangolin.
What is that thing?
Pangolin. It's like an armadillo type.
Yeah, it's like an anteater armadillo, something like that. Yeah. So you would know. You ever seen one?
Mm-hmm.
Yeah. Oh wow. Okay. Smuggled?
No.
No. Okay. I didn't know if it was illegally smuggled. You busted somewhere without. So symptom severity, severity, mild to moderate or no symptoms is 81% of people. 80+% of people have very mild symptoms or none. And so I've talked to a few who had it, and they say it's like the flu for a few days, 2 or 3 days, and then they're better. Not as bad as the flu. Other people, it's very mild. Severe, meaning in the hospital because your blood pressure's dropping, because you're needing oxygen, things like that, 14%. That's a pretty high rate. Critical means ICU, so you're going to need, pressors, you're going to need high flow oxygen, close observation. That's going to be about 5% of people, and then 2% of people are going to be ventilator dependent, and those people are on a ventilator for a long time because it damages your lungs a lot. And it's fatal, depending on where you're at, anywhere from 2, Italy's like 8-9%, so they have the highest fatality rate, and so it depends on where you're at, but that's kind of the fatality rates. Now, obviously, it's variable based on age, based on your accessibility of medical care, your other comorbid conditions, and the big ones we'll kind of get to, the risk factor conditions, age over 60. So that's one, and then it obviously gets higher and higher as the age goes up. It's not like everybody over 60 has the same risk. It's like if you're 90, you're probably not going to make it through it. If you're 60, you'll be worse, but you'll probably be okay. So it's variable. Diabetes, especially people with bad diabetes. The person that says, yeah, I'm on metformin, my A1C's always been 6, they're probably not at high risk, but the person who has bad diabetes doesn't fight disease well, so it's big then. Structural heart disease, congestive heart failure, things like that, those are big. Chronic lung conditions, people who have COPD, asthma, heavy smokers, all those things are big ones. Immunodeficiency, somebody that's on chemo, somebody that's got other causes for that, our rheumatoid arthritis patients and folks who are on those medicines. And then healthcare workers. We tend to have the highest rate of badness that happens to us related to this of healthy people, especially doctors and nurses more commonly. And we don't know why. The thoughts are, in a lot of these ICU settings, the doctors are working 24 hours. I mean, they're just taking care, and so they're not sleeping, they're not getting rest, they're stressed out, and they're getting huge viral loads because they're exposed to so many different people. And that's kind of the theory. But I forget, it's like in Italy, they have lost over 50 doctors so far. You know, I mean, so there's kind of a high rate there. But, you know, so it's serious, but if you go back, 2% of people are dying. That's when it's a lot less in South Korea where they are checking blood levels so they can tell if people have been exposed. Like, we can only tell if people have the virus right now. And so in places where they can check for exposure levels, they're finding that it's a lot lower because there's a lot more people had this than they realize. And so even at 2%, you think about 98% of people live. Okay, because I have talked to people all day, every day who are freaking out about this. And it's like, you know, yes, 2% of people are dying, but 98% of people live. That's pretty good darn odds, you know. I mean, so keeping those things in mind. If you go in for a bypass heart surgery, your risks are much greater than 2% that you're going to die. You know what I mean? So there's a lot of these things that you have, you know, significant risk for, and we don't think about that. But so it's serious, but we shouldn't be living in fear of it at the same time. Prevention, everybody knows what we're doing, right? Are we trying to contain this virus now? No. Okay, containment is when it was, you know, when it's in a small area and you can stop it from getting out of that area and get the virus to die on its own because you have kept it in a small area. We are not trying to do that because we are way beyond that point. And that is not what we're looking at. When everybody talks about flattening the curve, doing those things, we're looking at spreading this virus out so that we get it at a certain level, but not at an overwhelming level. Because if everybody got it at once, we wouldn't be able to take care of them. You guys wouldn't be able to bring them in. The hospital wouldn't be able to take it. And so if we can spread that out, we're able to take care of them. It's going to last longer is the problem. Okay, so when you do that, you save a lot of lives, but you extend the length of all this. And so, but in the end, what's going to stop the virus? Most likely, herd immunity or vaccination. Those are the only two things that are going to stop the virus, most likely, in the long run. And so it's going to take millions of people getting it for it to stop, or us getting a vaccine, whichever comes first. And so this is, you know, and so when you hear these time frames and all this stuff, it's like Dr. Fauci said, even after the peak is over, 95% of Americans will have no immunity to this virus. So we're still going to have all kinds of precautions and have to be careful. We're going to be living with this for probably at least for a year until we get an immunization, maybe more, to really, you know, so it's going to be a new norm for how we go in and take care of folks. So those are kind of the big things. Appropriate PPE is huge. That's kind of our biggest thing. Quarantining, how many people do you think that are supposed to be quarantined are actually doing a good job of it? Not many, right? A lot of folks are still out there. They're quarantined, but they're going to the grocery store. They're quarantined, but they're hanging out with their kids and their friends. And I mean, it's just amazing how many people just don't get it. If you know somebody who's supposed to be, have them look at the CDC website. There's great patient-driven information that will show you. You can go down through there and you click on, I'm not positive proven, but I may have been exposed, and it'll tell you exactly what you should do. It'll tell you what a home quarantine's about. It just lays it out for people very, very well. So have them look at that, because you guys are huge public information services. Exposure risk as a healthcare provider, the big thing is 6 feet. So if you cough right now, the chances of that getting to me are a lot lower if I'm here than if I'm right here, okay? So 6 feet is the big thing. And so you want to try to keep 6 feet from a person until you know that they're covered and you're covered. So the biggest, most important thing, who should have the mask? If you only had one mask in the ambulance and you go to the scene, who's the person that should have that mask? Patient, okay. They're the ones spewing out all this stuff. And so if you can slow that down, I mean, obviously contracting this is very low. So if you look, we have low risk exposures, moderate risk exposures, and high risk exposures. And that's kind of how it's divided down. This is CDC based, and so all the hospitals use pretty similar stuff. So low risk, if the patient has a mask, so if the patient doesn't have a mask, low risk is done. Okay, you are high or moderate automatically from that point on, no matter what you have on. So low risk, if they have a mask on and you have your PPE on, your risk is low. Some would even say none at that point. So like for me, I've been exposed and I had PPE on, they had a mask on. I am able to continue to work. I don't have to do any extra precautions. I don't have to be tested or anything like that because my risk is low enough, okay? So that's kind of the big key. If your risk goes up, moderate risk, so a patient has no mask, but you've got full PPE on, or they have a mask and you've got your mask and not everything else. So let's say you got your eye protection, your mask on, but you don't have a gown on and you do have your gloves. At that point, that's a moderate risk exposure. And so most places, and we would follow this too, is we would have you then wear a mask with patient contact for 2 weeks and monitor for symptoms closely. So you'd still be able to work. High risk, those patients, most places uniformly are sent home and quarantined at home for 2 weeks. And that's people who have no mask on you, no mask on them, within 6 feet, you get to go home for 2 weeks. Now, that can change depending on severity of illness in the community. So if we got tons of people who have this and we're trying to take care of them, some of those people will probably return into the workforce just because they have to. But that's the ideal. Does that make sense? Yes, sir.
Yeah, on this, are you differentiating between like N95 and surgical masks?
No. So the deal is that your risk is still very low with just a plain surgical mask. If they have a mask on also, you can just have a mask on. The place, and we'll talk about that is different, is if you are doing any aerosolizing procedures. So if you're doing anything to that person to make them cough, to make them, sticking a swab in their nose, intubating them, putting an oropharyngeal airway in them, bagging them, anything that you're doing in that way, you need an N95 mask on because you're just going to get a lot more particles in the air, and so your risk goes way up. What's the difference between an N95 mask and a surgical mask? And how it works. So, okay, yep, you got it. So the N95 seals tight, so all the air theoretically is coming in through the mask and out through the mask, right? And so versus a surgical mask, you're gonna get some flow through the mask. It's gonna decrease how much comes directly into you, but you're gonna get flow around it because it's not sealing tight. Most of that flow around it, interestingly, is when you breathe out. So you don't, when you breathe in, you pull in through it if it's pretty close and tight on you, but when you breathe out, you're gonna expire things around it. So that's the key. Does that make sense? So like right now, if I'm seeing a patient who has it or who we think has it, then if I'm going in the room and doing stuff to them, then I wear an N95. If I'm not, I wear a surgical mask to try to save N95s. Ideal world, and we got all the N95s in the world, we wear an N95 all the time. But we're not in that world right now, okay? So, PUI is a person under investigation. So these are people who they have not been tested, and then we are presuming they're positive, or they have been tested and we don't have the results back. How long is it taking to get the results back? Anybody know?
5 minutes to 2 days.
No 5 minutes, not pretty much anywhere in this state or in anywhere in the country standard-wise right now. There's those tests are coming, but they're not. There's one that's just been FDA approved, but it's not available yet.
It's the Abbott Labs one.
What's that?
The Abbott Labs one with the.
So the one that people are sending to folks. So those tests are not readily available yet. They're coming. I mean, but there's none
because
around
the
here.
equipment's already. There's like 14,000 of these pieces of equipment throughout doctors' offices.
Yeah.
I'm kind of curious because that's what we're told on TV that
No.
they exist and we just need the testing procedure.
It's not necessarily true. There's two. So there are tests that will do it, but not a lot. The two ways that we can test for this virus are we can test for antibodies to the virus, okay? And we can test with a thing called a polymerase chain reaction. That's your CSI test for DNA that we do, and that is the accurate way. The PCR test is the way we can know, do you have it right now? The problem with the antibody tests, and that's one of those tests that's a quick one, and in fact, people in Yellowstone County were getting those off the internet, and their sensitivity is very low, meaning that there's a lot of false negatives because it takes sometimes up to a week or more to start to show positive antibodies in that test. So there's a lot of people who tested themselves, thought they didn't have it, who may have. And then there's a high rate of false positives because it can pick up on antibodies from other coronaviruses. Because everybody in this room has had coronaviruses, okay? Just not this one. And so those tests in particular are bad. there are other tests that are coming that'll be a lot better, and some machines will run those that we already have that people are using for flus and things like that, but you don't have the kit for that yet. So those aren't really available, even though they're getting available. Does that make sense?
Right.
Now, right now what we have is we do a nasal swab, and it's a PCR test. That's the polymerase chain reaction. That's looking for the DNA from this virus that is sent to the lab, and pretty much it's a 3 or 4 to 1 week turnaround. Okay, so you can think, somebody may have been tested, waiting at home. How long do we say till they get really sick? So if they had it for a few days before they got tested, they could get really sick before we really know they have it for sure. So it's very possible, because if they've had it for 3 or 4 days, that 8-day window may come in when they're going into the hospital before their test is back. Those are all things we're thinking about. Plus, we're not testing people who are low risk. So if most everybody in this room came in and had symptoms, we would say, you stay home. Now, and I'll show you that's different because you're healthcare providers. But if you were just a random public, we would say, you stay home, you probably have it, don't expose anybody else, self-quarantine for 14 days or 7 days, depending. I mean, there's a lot of different protocols, but we would tell you to stay home, but we would not test you. Now, anybody in this room will be tested because you're a healthcare provider. If you're symptomatic, you will get tested. And so it's one of those things that you tell the person and we get you tested, okay? We have tests. We're able to test folks. We got plenty of tests to test if we had to test. Not enough to waste them on people who are healthy and don't expose other folks, but on healthcare workers we do. So
These are the 7-8 day turnaround tests.
So here's the deal. We are using the state lab here at the hospital, okay? The state lab initially was a day. We could get them done in a day. Well, as their demand went up, obviously they slowed down, and we're seeing 4 days, roughly 3 days, 4 days. Our tests through St. Vincent's and Billings Clinic are sent to private labs, and those are taken anywhere closer to a week. Because the problem with the state lab, they can't do too many, and so, but they're still doing ours. They're doing mostly inpatient stuff, but it is something that we have a little faster turnaround rate, but it's still 3 or 4 days. So that's who these people are, and like I said, they can get worse. They should know they're a person under investigation. They should have been clearly told that, but does that always happen? Does that always get communicated? No. So you always have to have your guard up. So our PPI ideal is face shield, right? Mask, pair of gloves under your gown, pair of gloves over your gown, so double gloves because of the doffing and donning, right? And so that's going to be ideal. Okay. So your shoes are still going to be exposed in that situation potentially. Parts of your clothes are. So, but those are our ideal. N95 mask, ideal. Problem is we don't have enough for that to be happening all the time. So when we have a patient that we're monitoring in the hospital, if we did that, we would have already burned through every mask in this town if we were doing that. And so, those are susceptible to being to prevalence of what we have. So if we have those things, then we're going to use them. If not, we use surgical masks. The deal is, and if we don't have a gown, we may run out of gowns, and so gowns are not quite as important. But when you get home, if you don't have a gown, your clothes are contaminated. You got to remember that the outside of your mask is contaminated. Those are all things. We're reusing our N95 mask. CDC says up to 5 times. So you can use it up to 5 times, or 1 all-day shift if you're just wearing it all the time. The problem is it's going to have contamination on the outside. You come to, and there's an electric wire laying there, and there's a guy that's coding, and you could save him. What are you going to do? What's number 1?
Make sure you're safe.
Scene safety. Okay, number 1, scene safety. That's where we're at with this. Okay, so let's say you get onto a scene and there's somebody who is having airway compromise, and you could either intubate that person, put a nasal pharyngeal airway in them, or do something to help them, give them mouth-to-mouth, start CPR, and you don't have protective equipment. What should you do with this situation? Scene safety. Okay, you got to remember that, because it does us no good for 3 of you to get it and us have to all of a sudden have 4 patients rather than 1. And so we have to be cautious with this. If you're like at St. Vincent's, I know what they're doing now is they have 1 room they're intubating everybody in. And that, if you have to be intubated, you're going to go in that room. And they're not going to, so we're not exposing other people if we can help it. We're not exposing ourselves. And so this is not a time to be a hero. and try to go in and do things without scene safety. And so if you're doing aerosolizing procedures, you've got to have an N95 mask on. If you don't have one and somebody else is doing that procedure, you got to get away, okay? So if they're in it, say Joel's intubating somebody and you're trying to help him and you don't have a mask, you can't help him. I mean, you just can't. You got to get away, okay? And so it's just, I mean, we have to be careful with this, and it is dangerous. We got to take care of people, but we got to remember scene safety. Need to minimize the number of people who respond. If the patient sounds like they're pretty stable and doing well, then we're going to send one person in there. You know, we're not sending 3 people in there. This is not the time for students and ride-alongs and things like that. We want to minimize. We want to have as few people to take care of the person as possible. Does that make sense? You know, drivers need protection. What kind of protection do drivers need?
Mask windows.
So they need a mask for sure. Even if you're just driving, you're never going to be near the patient, you still need a mask, probably need glasses. Mask is the big thing. So the key is if you did help out with the patient and now you're going to drive, what are you going to do?
Everything's gonna come
Doff, right? You're going to
Everything's
take,
gonna come off except the mask is gonna stay on.
Perfect.
And then you're gonna put, anything that touch the patient doesn't go with the cab.
that's right. So you want to keep the cab as clean as possible. So, you know, if you got your 2 layers of gloves on and you take everything off, other than your mask, you've got a clean pair underneath there. You can go with that. Otherwise, you're going to put a new pair on and get in the rig. Okay, and so that's going to be an important thing. You know, we'll kind of get to some of the others real quick. Anything else on questions on PPI stuff? No. Initial contact. You want to try to keep 6 feet distance. Okay. What's your first thing you want to do with that patient? Come on.
Get a mask on.
Get a mask on them. Yeah, you want to get a mask on that person right away. That's your number one thing. Grandma comes to the door and says, yeah, she's back here in the back. She's doing okay. Hey, why don't you put a mask on her and I'll be there in a second. I mean, you want that mask on that patient as soon as possible. That's going to decrease exposures immediately. So avoid touching your face. And they're doing studies on this, and it's amazing how many times we touch our face a day. Yeah, you're sitting there right now, right? It's like we just do it. And so it's hard not to do, but you know, you want to try not to, because this can get in from your hand to your lips, to your nose, to rubbing your eye. You got it, okay? And that's all it takes. We're not doing nebulizers, okay? So I know most of you guys don't do that, but we can give an inhaler, but we're not doing nebulizers. And so if they got a nebulizer at home and say, oh, can we do a treatment? No, because that aerosolizes the virus, okay? And then, so these are trying to avoid that contact. Yes, sir?
And that is with any patient or someone where you're suspecting?
So ideally, right now, it's coming. Okay, we've been pretty protected so far in Montana and here, but we're not going to be pretty soon. So if you were in New York City right now, anybody you see, you're going to assume they have it. Okay, and we'll get there. And it's probably safest and best if we have the gear to treat everybody that way from the start. Okay, because right now, I mean, you may have somebody who crashes their car who has this, and so then all of a sudden you find out 3 or 4 days later. Well, number one, they've exposed you, you've exposed your family, and it just becomes this public health nightmare. And so if we can and we have the supplies, we want to treat everybody that way. I mean, obviously, you know, there's a limit to our supplies, and we have to be careful with that. But you know, you do want to be as cautious as possible, and those are big things. Respiratory support, bagging them. We have filters. You guys have seen the filters. We have viral filters to put on. So you put that on. You got your mask, your filter, your bag, right? These guys know better, and so that is going to eliminate a lot of that getting through. Is it going to eliminate everything? No, because your seal is never 100%. You squeeze the seal. You know how they burp sometimes through the mask, where you blow a little too hard and there's not a good seal. You just shot a whole bunch of virus out that didn't go through that filter. So it's better than nothing. Ideally, so in situations where the patient comes in and they're crumping, if they come into the emergency room at St. Vincent's or Billings Clinic, they're not going to bag valve mask them. They're going to put them on 100% high flow oxygen, and they're going to tube them right there, because intubation generates less of the droplets than bag valving them. We don't always have that option, so we may have to bag them, but those are things we think about. Intubation, you want the best person doing it that you got, because you don't want to have to do it multiple times. And so those are big things. So it's kind of this debate, you know, you feel a little shaky on your intubation skills, you know, somebody's really good at the hospital, do you wait till you get there? And there's no good answer, you know, but you do what you feel like you have to do at that point. If you're intubating, or if you're putting bag valving, if you're putting a nasopharyngeal airway in, doing these things, where's the ideal place to do it? In the back of the ambulance with the door shut and the heat?
Outside.
Open air. If you can do it, the more open air, the better. The more open air flow, the better. So if you're in the ambulance and you have to do it, and you can get the door open, vents open, whatever you can do to get open air, you're better. If you can do it outside, better. You don't want to be around other people, so you don't want to do it in their home necessarily if you can avoid it, but you do want to be in open air if possible. It's not always possible, but it is better. You know, and those are big things. Questions on that? What about in the rig? What are we going to do in our rigs? I don't know if I have this on here specifically. What are we going to do in our rigs to try to decrease exposure to everybody in the rig?
Circulate air.
Circulate air. How are we going to do that?
With the vent system.
Okay.
Exhaust fan.
It's the exhaust fan in the back. What are we going to do in the front though?
Roll the windows down.
You could, but you know, you get a little bit of, you potentially could get some pullback and flow changes with that. The wind blows, you know, you can pull air in. So realistically, you want the vents on, okay. Do you want it on recirculate the air or not recirculate the air? No recirculation. If it's hot outside, when you're in the summer and this is happening, how do you want to do your air conditioning? You guys have max air and air in all the ambulances? So when you turn it to max air, what happens then? Recirculates. So everybody needs to remember that recirculates. You don't want to do that. So you want that air flowing through. You want it on high flow. You want that door shut. Okay, those are big things. So the other things are, you know, if you're exposed, people have to know. So public health has to know. Your medical officer, you know, whoever's John, Tim, you know, whoever's the lead provider on the call has to notify them, and we have to document all this because it has to be tracked, you know, and those are big things. And because then we're going to base it on that low, moderate, and high risk and see where you fall and what we need to do with you as far as taking calls, not taking calls, and all those things. Okay.
What if so the public health, but what if you're possibly exposed by somebody from another county?
Doesn't matter.
I mean, will it eventually get back to you as a person to?
Oh, I see what you're saying. So you take somebody to Billings and they're from Yellowstone County and they end up positive down there. Will we be notified? Ideally, yes. I mean, they should. So the public health nurse in Yellowstone County then should track everything back. You know, and they should track it back as far as even here, and they should notify us. They would call Sheila or those guys and let them know. Yeah. Now, that's ideally. Obviously, if it's crazy and we have hundreds and hundreds and hundreds of cases, maybe not. But at that point, we're all getting exposed anyways. Other things, you know, documentation of all that. You know, what you had on for your personal protective equipment. You need every item. Eyes, face, gloves, and gown. What you did, what you didn't have on, because those are important for us when we weigh out what's your risk factors as far as exposure. Did the patient have a mask on? All those things need to be written down in there, ideally. Okay. Standard distance. How long is it? What do we do with the ambulance? So let's say we take somebody to the hospital, and we're working multiple calls. We got one ambulance to go back and forth in. We take somebody down, and we set them out at the hospital. They take the patient. What are we going to do then with our ambulance? Shut all the doors and chart. So while you're charting, you want it opened up all the way. Everything that can be open needs to be open so that air can flow through. Okay. The 3-hour thing is in a stagnant room where there's no airflow. Okay. So the more airflow, the faster the better off we are as far as getting that virus out there. So you want the ambulance opened up when you're doing your charting. Okay. So then you're done with your charting. You're gonna come back here, right? You should get in your ambulance. You want to wear your ideally put your mask back on because that ambulance is probably not completely clean yet. CDC says by the time you do your call, do your charting, get the ambulance back, and clean it out all the way, it should be the airborne part should be good enough at that point, so that you should be able to then go get another patient if you needed to. And that's kind of their recommendations. If you keep it open and you do all those things, that you should that ambulance should be aired out And then you're gonna clean all the surfaces, ideally with a mask, glasses if there's gonna be any splashing, if you're spraying anything. And then you're gonna clean out, and gloves obviously. You clean all the surfaces, and then by that point you should be good. And that's kind of what the CDC recommends. So everybody got those sheets Tim sent out from CDC, yeah. And so you can read about that there too. And other stuff, other questions?
We're gonna talk about specific patient treatments.
Okay,
You know, for example, for that, all the different